and the topic is skin disorder in diabetes. As a speaker, we have Dr. Sudip Kumar Ghosh, HOD, Department of Dermatology, Anjikar Medical College. And to chair the session, we have Dr. Nilendu Sharma, Associate Professor, Department of Dermatology, NRS Hospital, and Dr. Guru Prashad Bhattacharya, one of the backbone of HTDDS, and Dr. Oritra Sharkar, one of the senior most dermatologists attached to Narayana Hospital, Howrah.
Do you have any CV for the speaker? Yes, it's there.
Acha.
So I request you to start the presentation.
So all of you must admit that mucocutaneous manifestations can precede, can appear simultaneously, or can appear after the onset of diabetes mellitus in many of the patients. Respected chairpersons, my respected teachers and dear colleagues, today my topic of discussion is mucocutaneous manifestations of diabetes mellitus. And the focus of my discussion is to present an overview about the specific cutaneous markers of diabetes mellitus, non-specific skin conditions associated with diabetes, and other dermatological consideration that should be undertaken in the diabetic patients. Now, why skin manifestations are important in the context of diabetes? There are several reasons. Number one, skin findings may be the first sign of metabolic disturbances caused by undiagnosed diabetes. And it may indicate the suboptimal management of known diseases. And often, it may be an indicator of pre-diabetic state. And skin complications of diabetes can provide clues to the current and past metabolic control of the disease. And several studies have shown that near about 30 to 91% of the diabetic patients, at least one dermatological complications may be there in the course of the disease. Now, the cutaneous manifestations of diabetes can be divided into several groups. Some conditions may corroborate with the cutaneous disorders of diabetes mellitus, that is associated with metabolic, vascular, neurologic or immunological abnormalities. They include acanthosis nigricans, acropodos, diabetic thick skin, limited joint mobility, sclerodermoid skin conditions, scleroderma, eruptive xanthoma, diabetic ulcers and cutaneous infection. We will discuss them one by one later. There are some disorders that are associated with diabetes but of unknown pathogenesis. They may include necrobasis lipoica, granuloma annulari, diabetic dermopathy, acquired perforating dermatosis and diabetic bulla. Some conditions are non-specific marker of diabetes. They may include yellow skin, nail, presence of pruritus, as already mentioned in the previous lecture, rubeosis faciae, palmar erythema, nail bed erythema, PPD, that is pigmented purpuric dermatosis, vitiligo, lichen planus, and psoriasis. And there are some iatrogenic manifestations due to either insulin therapy or oral hypoglycemic therapy. They may occur as an iatrogenic complication of diabetes. So let us start with the cutaneous disorder of diabetes mellitus that is associated with metabolic, vascular, neurologic or immunological abnormalities. So this is acanthosis nigricans. appreciate that there are some blackish velvety discoloration of the neck and in the periorbital region. So this is the classical presentation of acanthosis nigricans.
Recording in progress.
May also involve the interdigenous areas like axilla, palm, sole, and sometimes the oral mucosa as well. And the high concentration of insulin binding to IGF-1 receptor leading to expression of IGF-1 may stimulate the keratinocyte proliferation and thickening of the skin to produce such conditions. Skin tax is another important condition, important marker of insulin resistance. According to some study, it is more sensitive cutaneous marker for glucose metabolism disturbance than acanthosis nigricans. It may be found in near about a quarter of the patients presented with diabetes mellitus, and the relation between the number of skin tags and the fasting blood glucose is often found. These are usually soft, pedunculated or sessile papule or nodule present at the sides of the necks. Hand changes of diabetes is very important. This is the classical prayer sign due to limited joint mobility, thick skin, and digital sclerosis. They may occur due to the end product of glycosylation of collagen leading to thick skin. Eruptive xanthoma is another very important marker of diabetes mellitus. You can appreciate several discrete and coalescing small yellowish papules throughout the body, appearing very shortly as it drops. They often indicate poorly controlled diabetes mellitus leads to secondary hypertriglyceridemia. And there is accumulation of chylomicron and VLDL in the papules. They are usually associated with very high triglyceride level. As in this patient, you can appreciate very high triglyceride level in a young female presented with yellowish discrete papule all over the body in a patient with eruptive xanthoma. It can also affect the digits, palmar area also. Another patient presenting with eruptive xanthoma, the prototypical presentation. Scleroderma is another very important condition where you can get some induration and thickening of the skin, particularly near the nape of the neck over the shoulder region, and they are usually associated with diabetes, although it can occur in non-diabetic patient in other context, in the context of paraneoplastic manifestation also. So diabetes associated scleroderma adult. This is the classical presentation. Several food problems can also occur in the context of diabetes. So prevalence is near about 5 to 25% of the diabetic patient may have food problems, and mainly three mechanisms are responsible behind it. One is peripheral neuropathy, microangiopathy or macroangiopathy, and combination of both. So you may get diabetic foot ulcer, and the contributing factor for these foot ulcers are poor foot care, abnormal foot structure, and poorly fitting shoes also. So this is a classical tropic ulcer in an anesthetic foot. You may get some non-healing ulcer which may be infected or non-infected. You can get some gangrenous changes on the tip of the toes as a context of foot problem. Dry gangrene often is due to poor tissue perfusion leading to ischemia and necrosis of the skin. And the affected digit may sometimes drop out spontaneously, leading to autoinflammation. But in the context of weight gangrene, usually it is infected and require urgent surgical intervention. Regarding infection, several bacterial, fungal or viral infection can occur in the context of diabetes. And the main mechanism is due to hyperglycemia, there is increased chance of fungal and bacterial infection. In association, there is disturbed skin barrier and immune dysfunction, leading and associated WBC dysfunction, leading to impaired chemotaxis, impaired phagocytosis, and impaired T cell function. So there is increased potential to develop different cutaneous infections. So let us start with the fungal infections. Candidiasis is very common in the context of diabetes. usually there is interdigital candidiasis, and candidiasis involving the palms and soles, particularly in the washers who uses water frequently and washes their hand frequently. Candidiasis can also occur in the oral mucosa. This is very common. Several morphological variants can be found. And candidal pulmonoposthitis, it is a very important hallmark of diabetes. In almost 95 to 98% of the patients presenting with candidal pulmonoposthitis, they are either diabetic or in the future they may develop diabetes. Dermatophytosis, the data on dermatophytosis is less clear regarding association with diabetes, but we can count widespread dermatophytosis in the context of diabetes mellitus. Monoecomycosis, fungal nail infection, that can occur in 26% patients of diabetic patients in comparison to the 6.8% of the non-diabetic controls. So nail infections and the paranoical infections are very common in the context of diabetes mellitus. This is mucormycosis, a very well-defined entity in the context of diabetic ketoacidosis. You can appreciate there is blackish yellowish scar in the nasal vestibule, and also there is a palatal perforation. We have seen a lot of cases of this mucormycosis in the COVID era in our wards. So, and some of the patients are also diabetic. So, there is a distinct association of this mucormycosis along with diabetic ketoacidosis. Another patient, they are inevitably fatal without intervention. Bacterial infections are very common in the context of diabetes. You can get harantul associated with the necrosis of the hair follicle. You can get carbuncle. You can appreciate there are multiple orifices over a indurated plaque, discharging pus. So this is the hallmark of carbuncle. In all carbuncle patients, we should see the blood glucose level. Erysipelas is another important entity. You can appreciate there is a well-defined border here. That is in contrast to cellulitis, you can get this well-defined border in case of erysipelas along with some pudor in the appearance due to lymphatic blockage. Cellulitis is very common in diabetics, different forms of cellulitis. Sometimes you can also get necrotizing fasciitis. That is a surgical emergency as well. Erythrasma is a erythematous plaque or patch you can find in the groin areas or in the axilla, and this is the wood slump appearance on the other picture. You can appreciate the coral red appearance on the wood slump in the erythrasma. There are several disorders that are associated with diabetes mellitus but of unknown pathogenesis. This is a classical presentation of necrobiasis lipoidica. You can delineate a well-defined plaques over the shin bone with some underlying telangiectasia, some yellowish atrophic area is also visible. Sometimes these lesions may be ulcerated as well. These are very common in the context of diabetes mellitus. Granuloma annulari is another important entity that can be found in generalized distribution in the setting of diabetes. There are some annular plaque studded with some skin-colored non-tender papules at the periphery. These are the hallmarks of granuloma annulari, and generalized granuloma annulari may be associated with diabetes mellitus. Another picture showing generalized granuloma annulari. You can appreciate some teeny skin-colored papules at the margin of this annular plaque. Diabetic retinopathy, my previous speaker has already elaborated on it. It is found in 10 to 50% of the diabetes, and these are the cutaneous signs of microangiopathy. So it may be associated with peripheral neuropathy, coronary artery disease, nephropathy, or retinopathy. So this is a clinical marker of severity of systemic diabetic complications. This is another entity known as acquired perforating dermatosis. These are some keratotic papules, and there is a keratinous plaque is there in the center of this keratotic papule. This is known as acquired perforating dermatosis. These are also very common in the context of diabetic nephropathy. So half of the acquired perforating dermatosis patient, they are diabetic, and amongst them, many of them have nephropathy. decorum or diabetic bulla. The bulla are usually non-inflammatory in nature. You can appreciate there is a tense bulla over there and a flaccid bulla over the wall of the great toe on the non-inflammatory base and without any features of friction or other inflammation. Rubeosis, that is redness of the face and other areas of the body. They are characterized by a chronically flushed face and neck. These are more easily appreciated in dyspeptic skin type 1 and 2, particularly in the Western population. The reddish complexion is believed to result from microangiopathic alteration and superficial facial venous dilation. Palmar erythema is also a very common presentation of diabetes, particularly in type 2 diabetics. This can be also found in other conditions like thyrotoxicosis, pregnancy, chronic myeloid leukemia, rheumatoid arthritis, and other medical conditions. So their prevalence is around 4% in diabetic patients. Pigmented purpuric dermatosis, they can coexist in near about 50% of the diabetic patients. There are some brownish papule you can find out over the lower extremities. Psoriasis, that is a presenting with usually dull red erythematous plaque with silvery white scales on different parts of the body. And patients with psoriasis have a 1.5 times increased risk for developing diabetes mellitus. And patients with severe psoriasis may have twice the risk of coronary artery disease. Lichen planus is another entity. Lichen planus is usually appreciated by some vivacious papule or plaque. Or vivacious papular plaque. They are extremely itchy, often exhibits the features of coagulation, and about 25% of the patients with lichen planus, they may suffer from diabetes mellitus. Vitiligo, it can be generalized also. They are more commonly found in type 1 diabetes in comparison to type 2 diabetes, usually presenting with depigmented patches on different parts of the body without any surface change. And gelosis and pruritus are one of the most common cutaneous manifestation of diabetes. My previous speaker has already elaborated over the pruritus. So you can prove or establish the diagnosis of anidosis by negative starch iodine test. And there are some iatrogenic complications. Lipoatrophy at the injection site of insulin, that is a loss of local subcutaneous fat, you can find out. It can be found in about 25% of the diabetic patients having insulin therapy. And several oral hypoglycemic agent can lead to different types of skin manifestations. For example, in case of metformin, the patient may have allergic reaction, leukocytoplastic vasculitis, erythema multiforme, and psoriasiform lung eruption. In addition, a patient having metformin therapy for a longer time period, patient may have blackish complexion of their skin due to vitamin B12 depletion. And patient also may have some features of vitamin B12 related neuropathy of the lower limbs. Glibenclamide may lead to pemphigus vulgaris and psoriasiform drug eruption. And recently, some gliptins are seen to be associated with the appearance of bullous pemphigus. Sulfonylurea can lead to cutaneous photosensitivity, lichenoid drug eruption. Acarbose are associated with acute generalized exanthematous pustulosis, presenting with some teeny pustules, non-follicular pustules on an erythematous base, and generalized erythema multiforme. So, the take-home messages are, nearly all patients with diabetes mellitus show diabetes-associated skin disorder. These cutaneous findings may predate, may appear simultaneously, or may appear after the diagnosis of diabetes mellitus. And certain cutaneous findings should be interpreted as warning sign of diabetes mellitus and may indicate poor glycemic control. So, a multidisciplinary approach must be contemplated to treat such patients. Thank you. Thank you all for your patience here.
Thank you, Sudip, for your nice presentation that covered almost everything, and you are on time also. I'll expect some questions from the floor. You covered everything. Just one thing I could not find, that is, rare possibility of Steven-Johnson syndrome from some of the drugs, especially sitagliptin, that has been reported. And there are some presentation, as he mentioned, that may even very strong suspicion of a diagnosis of diabetes, which is not made so far, but the diagnosis of skin finding may suggest us to suspect, like eruptive xanthoma, like melanoposthitis. These are very common antecedent in these events of diabetes.
Hello. Do you mean leukocytoplastic vasculitis is Sandberg's disease? Sandberg's disease?
No, they are not synonymous. Actually, by the term leukocytoplastic vasculitis, clinically we found a features of cutaneous small vessel vasculitis. And the hallmark of cutaneous small vessel vasculitis is palpable purpura. So, this palpable purpura on endoscopy, that is, if you press the lesion with the help of a glass slide, you can find partial blanching. One component is due to the inflammatory component that may blanch, but there are some extravasated RBC as well that will not blanch. So, the hallmark of small vessel vasculitis is small vessel palpable purpura, which is partially blanched. On the other hand, in case of pigmented purpuric dermatosis that you can find particularly over the lower limb below the level of knee, there are some brownish pigmentation of the lower limb, brownish macule or coalescing patches are there. There, usually the hemosideral pigmentation due to long-standing job of the patient is usually involved due to prolonged standing or prolonged dependency of the lower limb. That is the main factor for that. So, small vessel vasculitis is much more dangerous condition to identify and treat.
Thank you.
So, any other question? So, we conclude this session, a very elaborate session by our eminent sir. Okay.
Thank you so much, Speaker. Thank you, Chairperson. We have a small gift for you. I would like to request Dr. Guruprasad Bhattacharya to please stay with us for the next session.